kind of a brief review. So this is kind of a brief review. So I did just was just reminded to start the recording. So thank you very much, Jada. So follow up on the last video. Hopefully, if you are watching these, you did just watch the last one, then you're watching this one. So glad we got it started before the new content. So thank you, Jada. So for that, borderline personality disorder, oftentimes it seems like there is a genetic component here, and also childhood abuse. So that makes a lot of sense when you're thinking about insecurity and not being securely attached and not having stability in relationships. You could see how that might follow from that kind of preceding event of childhood abuse. So with this, another thing is an irrational belief that you're powerless, unacceptable, and that others are hostile. Oftentimes there's also hypervigilance. So this can lead to a lot of different kinds of behaviors. If you think you yourself are powerless and other people are hostile, it might make you very afraid of other people. Might make you not want to interact and develop relationships with people. If you think you yourself are an unacceptable person, it might lead to a lot of negative self-image. With this, you can also have that kind of, it's not a manic shift in the same sense of bipolar, you have mania and depression, but it's similar in some ways. So it can be a really hard one for people to live with borderline personality disorder, because these shifts happen without their intention. So it can be really difficult. A person if you're in a relationship with a person, so whether it's a friendship or even a close like partner relationship with someone with borderline personality disorder, they definitely need a lot more patience and care than you might expect to be putting into a relationship. So that can make it pretty difficult. And then we'll talk about treatments for these pretty soon in chapter 13. So let's talk about suicide. I didn't want to end off on, borderline personality disorder and antisocial personality disorder aren't really rosy topics for sure, but suicide's definitely not a rosy topic. So I didn't really want to leave off on that last time. So with it, suicide is the third leading cause of death in early adolescence, and it's also a pretty high cause of death in early adults as well. For every completed suicides, there's about 25 attempted suicides on average. That doesn't mean that for anyone who completes a suicide, they've attempted 25 times. But if you take for any one person who has completed a suicide, there's probably about 25 others who've attempted. So there's a lot to go into this. So biology with genetics, neurotransmitters, the same kind of neurotransmitters that are affecting in depression, physical health as well. Especially if we're talking later adults, or people with chronic illnesses, their physical health can be a big cause of why they attempt or complete suicide. So with that, what kind of puts you at high risk is that desire to die plus having a means to die. So if you have a friend or relative who talks about wanting to die as well as having that means, that is really high risk. So with this, there are cultural variations here by ethnicity and nationality. So for example, chronic economic hardship is a high risk factor for suicide. I feel like that's not really a surprising fact or statistics. Native Americans, especially female Native Americans, have a very high suicide rate, attempt and completion, because basically the chronic economic hardships, the cultural and economic factors that lead to such a difficult life for Native American people. So with that, people in these countries, Guyana, how do I even pronounce that? For some reason, I literally cannot remember how to pronounce that. South Korea, Sri Lanka have the highest rates of suicide. Saudi Arabia, Lebanon, Kuwait, and Haiti have the lowest rates. And so some of that is because of cultural values of the area. So it's seen as more of a negative thing in some of these countries, like really, really bad culturally. So with that, cultures that emphasize honor are more likely to have suicide. And when there is no religious prohibition against suicide, it also tends to be more common. Women are more likely to attempt, and men are more likely to complete a suicide on average. Not to say women are not at risk. We just talked about how Native American women specifically are at very high risk. So when someone is threatening suicide, do these things. Take it seriously, calmly ask simple questions, be a supportive listener, emphasize that the unbearable can be survived, not that they're going to be better after the fact, or that things will get better, but that they can survive this. That's more important, or more realistic as well, especially if there's these chronic things that are leading to the thoughts of suicide. Saying that it's going to be better and then it actually doesn't get better, that can be harmful. So staying with the person until help arrives, especially if it's an immediate need, not leaving them alone, especially if they have that desire and the means. Don't leave them alone. So encourage them to get professional help, and that can be a really hard thing, because especially when suicide is connected to depression, one of the symptoms of depression that's really common is essentially a lack of motivation to do things, a lack of motivation to reach out to friends, to go to work, to do schoolwork, all sorts of things. And it includes seeking professional help, because that's a hard thing. That's a new thing. It's a different thing. Even if they are in therapy, they might not want to seek out help. They might feel bad about wanting suicide. So that if you're supporting someone who's threatening suicide, you might want to seek out help for yourself as well. So we talked about this last class period, but essentially therapy is not just for people who have disorders specifically. If you're feeling just too anxious and you want to learn some anxiety reducing techniques for classes and before tests, that's a perfectly valid reason to get help. Honestly, any reason that you might think to want to get help or think, hey, should I get help? It's probably a very good and valid reason. So some things not to do. Don't ignore the warning signs. If someone is stating something about it, it can be hard for them to reach out anyway, so definitely pay attention. Don't refuse to talk about it. It can be a very difficult topic. It's not going to be a fun time, right? Don't react with horror or disapproval. So that one can be really hard, because you probably are scared and worried, right? You probably wouldn't approve of them taking their life in many cases. So try not to react that way. That's not going to be as helpful. Don't try to, I'm lecturing specifically. Don't say things like, you should be thankful for X, Y, and Z. That actually makes me wonder. I've been seeing a lot of social media posts about things people are thankful for recently, because Thanksgiving is coming up. So I do wonder just if there's any research. I know there's research that shows rates of attempts as well as completed suicides rise around the holidays. I wonder if seeing more or fewer of messages of thankfulness from people around is a risk or a protective factor. I don't know. That's interesting. I'd need to look at the research. Maybe a good question paper. You've got one more question paper to do. Actually, I think I've got the schedule up here. So the last question paper is due the 10th. So that might be a topic I would do for a question paper, because that sounds like an interesting topic right now. Don't offer false assurance that everything will be all right. Like I mentioned a minute ago, everything might not be all right. The same chronic problems that are there might still be there after, but they can be survived. People can pull through. People can make it through those hard things and still be in those hard things and survive them. So don't abandon the person once the crisis seems to have passed. You really might need that extra space and time for yourself after supporting someone. but don't just abandon that person. It can be hard with a friendship or a relationship that takes more of that energy out of you. But especially for a person in this kind of situation, they need that support. If they probably have, if they have any support, that's better than no support. So try your best to be that support and get help yourself to cope with those things also. So, questions about that? Again, I know it's not the rosiest topic, but these tips of things to do are definitely supported by a lot of research and can be very helpful. All right, so let's talk about the stigma of mental illness. So your book does a pretty good job, as opposed to other introductory psych textbooks, talking about the stigma that people with mental illnesses face. So when you have people who have mental illnesses, oftentimes there's a big stigma, similar to other stigmas that exist. People with mental illnesses have stigmas. So one of the key things here is that people who have had and recovered from mental illnesses are reluctant to come out and talk about it, to say that they did have a mental illness or that they do, because of the stigma. Posting it on social media, for example, it's hard for people to do that because maybe it'll affect a possible job opportunity in the future. Maybe other or friends might look at them different because of those challenges, especially when people still have the stigma that people with mental illnesses are weak or not able to make it or push through things or whatever things that they say about it, or the ridiculousness. So I think we may have watched this in relation to one of the disorders. But let me just check really quick. Did we watch last class period? I'm thinking we skipped this person's discussion about her mental illness. Did we watch this last time? Does anyone remember? Here, this is her. She does do a good job talking about the stigma. Okay, we didn't. Thank you very much. She talks about the stigma as well as the symptoms and her experience with the disease. So it's a really good one to talk about in relation to stigma as a whole. So let's watch this. It's also relevant to some of the disorders that we've been talking about.
One in 4 people suffer from some sort of mental illness. So if it was 1, 2, 3, 4, it's you, sir, you. Yeah, with the weird teeth, and you next to him. You know who you are. Actually, that whole row isn't right. That's not good. Hi, yeah, real bad. Don't even look at me. I am one of the 1 in 4. Thank you. I think I inherited from my mother, who I used to crawl around the house on all 4s. She had 2 sponges in her hand, and then she had 2 tied to her knees. My mother was completely absorbent, and she would crawl around behind me going, "Who brings footprints into a building?" So that was kind of a clue that things weren't right. So before I start, I would like to thank the makers of lamotrigine, sertraline, and reboxetine, because without those 2 simple chemicals, I would not be vertical today. How did it start? My mental illness started, well, I'm not even going to talk about my mental illness. What am I going to talk about? Okay. I always dreamt that when I had my final breakdown, it would be because I had a deep Kafkaesque existentialist revelation. Or that maybe Kate Blanchett would play me and she would win an Oscar for it. But that's not what happened. I had my breakdown during my daughter's sports day. There were all the parents sitting in a parking lot eating food out of the back of their car, only the English, eating their sausages. They love their sausages. Lord and Lady Rigor Mortis were nibbling on the tarmac. And then the gun went off and all the girlies started running and all the mummies went, run, Clemmy dear, run! Run like the wind, Veruca, run! And all the girlies running, everybody, except for my daughter, who was just standing at the starting line, just waving, because she didn't know she was supposed to run. So I took to my bed for about a month, and when I woke up, I found I was institutionalized. And when I saw the other inmates, I realized that I had found my people, my tribe, because they became my only friends. They became my friends, because very few people that I knew, I wasn't sent a lot of cards or flowers. I mean, if I had had a broken leg or I was with a child, I would have been inundated. But all I got was a couple phone calls telling me to perk up, because I didn't think of that. Because, the one thing that you get with this disease, this one comes with the pain.
So a really good example of a common experience of people with mental illness is that, especially when compared to something like a physical ailment that is obvious, like a broken bone, you have a cast there, people might help open the door for you or something like that. Versus even with a chronic illness, even if it's a physical illness, you might get people who are dismissive of it. And especially with mental illness, there's a lot of stigma that it's because of something you did, because you're not perking up, you're not working through whatever it is, not that maybe it could possibly be chemical imbalance, genetic predisposition, factors that you've experienced in your life, realistic responses to trauma, things like that. So it's a common experience and a really hurtful one for a lot of people with a mental illness to have it be so dismissed.
Package is you get a real sense of shame because your friends go, oh, come on, show me the lumps, show me the x-rays. And of course, you got nothing to show. So you're like really disgusted with yourself because you're thinking, I'm not being carpet bombed. I don't live in a township. So you start to hear these abusive voices, but you don't hear one abusive voice. You hear about 1,000 100,000 abusive voices. Like if the devil had Tourette's, that's what it would sound like. But we all know in here, there is no devil. There are no voices in your head. You know that when you have those abusive voices, all those little neurons get together, and in that little gap, you get a real toxic, I want to kill myself kind of chemical. And if you have that over and over again on a loop tape, you might have yourself depression. Oh, and that's not even the tip of the iceberg. If you get a little baby and you abuse it verbally, its little brain sends out chemicals that are so destructive that the little part of its brain that can tell good from bad just doesn't grow. So you might have yourself a homegrown psychotic. If a soldier sees
So I know the research she's talking about, like making that point, and like from a layperson understanding it in that way, I can see like the jump there. So just as a factual like fact check here, children learn how to process and handle their emotions largely from the direct care and responsiveness from their caregivers. So if they're not responded to appropriately or harmed, essentially what they learn through both behaviorism and cognitive factors, their neurological development, their empathy might be stunted in its development. So not that it disappears or is deleted entirely, but just that they might learn other survival skills that look harmful to other people because that's how they had to survive. So I think the term psychotic or psychopath, especially from someone with a mental illness, is probably not an appropriate way to discuss it. So that's the one part of this video that kind of grinds my gears the wrong way. So I just definitely wanted to point that out. And like I see where the research, where she's coming to that conclusion and trying to describe it for a lay audience. Also trying to like sensationalize it a little more, but I do think it does it a little bit of a disservice in this specific case. A lot of what she says is really pretty accurate for like a lay audience, like she's talking to here at TED.
His brain blown up. His brain goes into such high alarm that he can't actually put the experience into words, so he just feels the horror over and over again. So here's my question. My question is, how come when people have mental damage, it's always an act of imagination? How come every other organ in your body can get sick and you get sympathy except the brain? I'd like to talk a little bit more about the brain because I know you like that here at TED. So if you just give me a minute here, okay. Okay, let me just say there's some good news. There is some good news. First of all, let me say we've come a long, long way. We started off as a teeny little one-celled amoeba, tiny, just sticking onto a rock, and now, voila, the brain. Here we go. This little baby has a lot of horsepower. It comes completely conscious. It's got state-of-the-art lobes. We got the occipital lobe, so we can actually see the world. We got the temporal lobe, so we can actually hear the world. Here we got a little bit of long-term memory. So, you know, that night you want to forget when you got really drunk? Bye-bye, gone. So actually, it's filled with 100 billion neurons just zizzing away, electrically transmitting information, zizzing. I'm going to give you a little side view here. I don't know if you can get that here. So zizzing away, and for every one, I know I drew this myself, thank you. For every one single neuron, you can actually have from 10,000 to 100,000 different connections or dendrites or whatever you want to call it. And every time you learn something or you have an experience, that bush grows, you know, that bush of information. Can you imagine every human being is carrying that equipment, even Paris Hilton? Go figure. But I got a little bad news for you, folks. I got some bad news. This isn't for the 1 and 4. This is for the 4 and 4. We are not equipped for the 21st century. Evolution did not prepare us for this. We just don't have the bandwidth. And for people who say, oh, they're having a nice day, they're perfectly fine, they're more insane than the rest of us. Because I'll show you where there might be a few glitches in evolution. Okay, let me just explain this to you. When we were ancient man, millions of years ago, and we suddenly felt threatened by a predator, okay? We would, thank you, I drew these myself. Thank you very much, thank you. Thank you. Thank you. Anyway, we would fill up with our own adrenaline and our own cortisol, and then we'd kill or be killed, we'd eat or we'd be eaten, and then suddenly we'd defuel and we'd go back to normal. Okay, so the problem is nowadays with modern man, when we feel in danger, we still fill up with our own chemical, but because we can't kill traffic wardens or eat estate agents, the fuel just stays in our body over and over. So we're in a constant state of alarm, constant state. And here's another thing that happened. About 150,000 years ago, when language came online, we started to put words to this constant emergency. So it wasn't just, oh my God, there's a saber-toothed tiger, which could be. It was suddenly, oh my God, I didn't send the email. Oh my God, my thighs are too fat. Oh my God, everybody can see I'm stupid. I didn't get invited to the Christmas party. So you got this nagging loop tape that over and over again that drives you insane. So you see what the problem is. What once made you safe now drives you insane. I'm sorry to be the bearer of bad news, but somebody has to be. Your pets are happier.
That joke is your pets are happier than you are. But I think we've got through most of the relevant stuff there. I like the connection there with evolutionary aspects of psychology, evolutionary psychology that we've talked about earlier on in class. So let's jump back here and talk about more specifically the stigma, because it was really relevant how genetics, how we've evolved these tendencies, how it might lead us to be predisposed to things like anxiety as one really clear example. But let's jump into, I thought there was one other class of disorders before we jump to chapter 13. I guess not. We're in chapter 13 now. Or am I missing pieces of stigma? I might have accidentally deleted them. So, oops, I do think that made some of the main points. One of the things that we didn't talk about was the physical health risk as well. So having that stigma, having that anxiety, having that essentially struggle with stigma around a mental illness puts people who have a mental illness at a higher risk for other physical ailments as well, even if it's just things like being more prone to infection. So the body, the cortisol levels, the whole system. One other aspect of that was, well, you're going to be a little more likely to even catch colds. So that is also a bad thing. So what are things we can do to combat stigma? Well, one is talk about them in Psych 100 level psych classes, having people who do have mental illnesses, who are experiencing symptoms, talking about it in settings like TED, having friends or family members talk about it, allowing them the space to talk about it and talk about their symptoms and try to understand them. Looking up research, now you've gained a lot of skills. By the way, with that, I've graded all of the, oh, sorry, wrong class. The other class, just my quicker class, that's half of the semester. They just got one of their question papers in and graded back. So that's not this class, I'm sorry. You've got your last question paper coming up in a couple weeks, but you've been doing really well on those, and now you've developed those skills to find good research. So when you hear someone talk about, this is the disorder I have borderline personality disorder, I'm suffering from anxiety or depression, you can find good resources on those topics. For disorders specifically, the APA website, the American Psychology Association, is a pretty good resource for basic information, and as well as general kinds of treatment plans, things that you can do to support people with disorders. So that's actually a really good resource too. That's kind of boiled down that where you don't have to be reading the research papers to distill that. They've kind of already done that for you. So that's a good source as well. All right, so chapter 13, we'll be talking still about a lot of these symptoms as well as about a lot of the neurological things that are happening to cause some of these disorders, and then how some of these treatments might help throughout this chapter. So the main things that we'll talk about are kind of in these boxes. We'll talk about biological therapies, psychotherapy, and sociocultural approaches. So with that, therapy is essentially any kind of method that we're using to relieve the suffering of individuals with psychological disorders, whether that's trying to reduce the symptoms, reduce the anxiety and stress and pain of the symptoms, or getting the disorder completely done away with. So psychological approach, you can probably imagine, since we're near the end of the book and the end of the class, what is the psychological approach? Well, it's oftentimes clinical psychology, doing non-medical interventions, counseling, social work, those kinds of things are the psychological approach. Talk about strategies. When we talk about cognitive behavioral therapy, a lot of that is a psychological approach. You've also got the biological approach, and a lot of that is biomedical therapies. And so one of the most common is drugs. So using a stimulant for ADHD or an antidepressant for ADHD, for example, both of those might be tried as a biomedical therapy or within that umbrella of biological approach to treat that specific disorder. Psychiatrists are often going to be focused on the biological approach, and this makes sense. A lot of their training, again, psychiatrists went through medical school, so they went through the same medical school, well, not necessarily the exact same medical school as your family practitioner, but they went through those same kinds of courses, and then they did their residency in psychiatry. A sociocultural approach looks at individuals as part of a sociocultural system. So it tries to intervene within that system, give community supports, things like that, that try to change the system in some way to help that individual or the individuals dealing with, say, chronic economic problems, for example. would be an example of looking at the sociocultural approach, trying to change the material standing of those people so that that stressor and that risk factor is removed. All right, so with this, for psychotherapy, when we look at a lot of different disorders, looking at psychotherapy versus a placebo, so whether the placebo is like a sugar pill or the placebo is some other kind of treatment that's not actually the actual psychotherapy or no treatment, we can see that for a lot of disorders, I forget which specific disorder or if this was on average, these numbers, most people do improve with psychotherapy. So factors in successful psychotherapy, so this goes for many, many, many disorders specifically, is the therapeutic alliance. So that relationship really between the therapist and the patient is one of the biggest and most important keys for effective psychotherapy. The therapist needs to do a really good job excuse me, at monitoring that relationship, seeing how the person is receiving what they're delivering, if the person is trying out the things that they're requested, the patient is trying out the things that are requested. Does the patient trust the therapist? What is the therapist doing to help get more trust or get more buy-in to the ideas of how we can do X, Y, and Z to treat these symptoms or relieve these problems? So that therapeutic alliance is essentially an alliance between the patient and the therapist, that they both trust and feel they're working together for the betterment of that patient. And if you don't have that therapeutic alliance, if you don't feel like your therapist is there for you, if you don't feel like they're doing a good job or they're giving you the care or the time that you need, then seeing another therapist is a good idea. Oftentimes, if you say that to a therapist, referral, they might give you another person, right? While these therapists train to work to click with people and essentially be a person that they can trust, sometimes that relationship just doesn't emerge as easily or naturally between a therapist and a patient. And so trying another one can be beneficial. With that, the therapist's expertise and personality is a big key. So if the therapist's expertise is in, let's say, depression and anxiety, and then someone comes to them with ADHD, for example, they might not be as expert in that area, and so they might not be the best choice. So just like if you're looking for a specialist in the field of medicine, if you have I have family members with multiple sclerosis, which is a chronic illness, and I have family members with fibromyalgia. So they would look for a specific medical practitioner that knows about that topic and then go to see them because they could give them more relevant and specific direction for them. Same if you have some kind of diagnosed mental disorder, going to someone with that kind of expertise is going to be better than, is going to be better. Any help can be more beneficial, but the more tailored it is for that individual patient, the better it's going to be. So the client does need to be actively engaged as well. So if it's you as the client or if it's your client as a client, they do need to be engaged. A therapist can do things to try and get the client more engaged, but there does have to be some of that motivation from the client side. And another big key, and this goes for all areas of work generally, is using up-to-date research. So you wouldn't want a rocket scientist using older research because then they probably wouldn't know about newer fuels and engineered solutions to problems that they think or that they come upon. You would want your doctor to be using the most up-to-date research. You also want your therapist or psychiatrist to be using the most up-to-date research as well. So, who was a psychodynamic theorist that you remember? So we just talked about him pretty recently in the personality chapter. Can anybody name a psychodynamic theorist? Good. We've got Freud and Jung. Um, I believe Jung was also psychodynamic. He was a little bit after Freud and took some of his ideas and added on some of his own. Yep, Freud and Jung. So another hint here, if nobody had gotten it, is psychosexual. Does that ring a bell? So that was obviously Freud for that one. So the emphasis of the psychodynamic approach is the early childhood experience. Hopefully this sounds familiar. We talked a lot about psychodynamic approach in the chapter on personality. The idea that there are unconscious conflicts, that we had some kind of driving motivation driving us to do things, and that motivation was outside of our conscious perception. And so the therapist would try to interpret your current behavior to uncover what these unconscious conflicts are. So, what were your conflicts? What does your behavior currently, or maybe your dreams or your ideas, what does that say about the unconscious conflicts? If we can then solve those unconscious conflicts, then the current presenting problems would go away. So, those goals are the therapy are identifying those unconscious conflicts, and mostly that's done by talking about it. So this is why you often see pictures of Freud with a patient on a couch and essentially just talking about things, and the therapist would pick up on things. They would be able to understand what the conflicts are that are driving your motivations for your behaviors. So the therapist could figure it out because they were specially trained, but you wouldn't have access to what those conflicts were. So positives of this approach, we talked about positives of it when we were talking about personality. It did have success for many problems. When there was a positive, supportive, and healthy relationship between the therapist and the patient, there were positive changes that were made. So looking back at old data, you can even see that statistically, there were positive changes. So a lot of that comes to this point, the therapeutic alliance that we talked about. If there was a good therapeutic alliance between some of these therapists and their patients, there were positive changes that could be made. So psychoanalysis from Freud did free association, catharsis, interpretation of the things people were saying or thinking or their ideas, dream analysis. Honestly, going into these in any more depth, your book does go into them in more depth, but for us, if you recognize these words and you remember them already from your reading, that's all you need to know. Transference and resistance. So transference specifically was usually trying to use a defense mechanism to transfer feelings or motivations from whatever their actual source onto the therapist, so onto Freud himself. So getting the patient to transfer that to them and then being able to work on the unconscious motivation. So contemporary psychodynamic therapies are a lot different. So they still focus a lot on the unconscious thoughts. Early childhood is still more of a focus, but with that, there is a lot more. Some of this sounds really similar, right? So gaining insight into repressed conflicts, but these aren't necessarily completely unconscious conflicts. There's also, did you actually have like literal conflicts in childhood with your parents? Did you fight with them? Can be that as well. So it views the conscious mind as more powerful than Freud did. So what are you thinking now? What are your motivations now? What do you want to do? So a little bit of maybe that humanistic piece is kind of bled over into that. But really what it is that as scientists actually started to test Freud's methods, they found certain aspects of it, like that therapeutic relationship, were really effective. But they took the theories and they continued to evolve and build on them and make them better with new data. And so now we have newer psychodynamic therapies that exist. So there is also a lot less focus on sex as a motivator. More often the motivator is like sociocultural factors that essentially give you your goals and drive you to do things. So based on those sociocultural factors that are driving you to do things and the challenges that you're presented with will kind of tell you where those unconscious conflicts are. So humanistic therapies. So again, I won't go in a ton of depth about humanistic psych as a whole, feel free to review, what chapter is that? Chapter 9 on impersonality. So with this, the emphasis of this approach is the conscious thoughts of a patient, the things that are happening in the present. So what are their goals? What do they want to do to self-actualize? So self-healing and self-fulfillment. So helping them set goals and reach goals themselves agentically. So using their own choice and agency to do things for themselves. So some of the goals of therapy of here are the patient's self-understanding. So rather than the therapist being privy to some kind of unknown thing, unconscious motivation, the humanistic therapist would say, well, the person needs to understand their own self, so that the causes of their conflicts or problems or stresses or anxiety or symptoms are understandable to them. And they want that person to then grow, become a whole person, become whole in and of themselves. So whatever they feel that is. So if you remember Maslow's hierarchy of needs, self-actualization at the top, that basic idea, letting the person become kind of the best person that they can be. So Rogers client-centered therapy is a humanistic approach. We talked about Rogers in personality. Oftentimes Rogers used the unconditional positive regard. And so essentially listening, giving a reflective speech, kind of just responding, saying almost the same thing back to the patient, so they knew they were listening, felt like they were being heard, and giving them kind of a positive environment and sense. I didn't check this video to see if it was working, because sometimes this one, I can always find it, but sometimes whoever puts it up deletes it and someone else puts it up later. So this is actually a part of a session with Carl Rogers and this patient, Gloria. An interesting thing is this specific patient went and saw a couple other therapists. So we're not going to watch all of these, but I think she went and saw 3 different therapists. So here in these YouTube links, yeah, actually it looks like this person has uploaded quite a few of them. So I think they did a psychodynamic and a behaviorist exclusive approach in therapy as well. But the Carl Rogers one is really useful to see how this actually works, how a humanistic therapist would actually act and respond and interact with a patient. So yeah, I think that's a good preamble before watching this. We probably won't watch the whole thing either, just enough so you get a sense of kind of what goes on in the back and forth here. And look for these things that we just mentioned. Look for that active listening, look for the reflective speech from Rogers, look for this unconditional positive regard, and just being kind of empathetic and trying to be genuine, or being genuine, maybe not trying to be.
If I have any success in creating the kind of conditions that I described initially, then we may be able to see some of these changes in this client, even though I know in advance that our contact is going to be very brief.
So for each of the therapists that went through essentially this documentary, they had them kind of describe in the beginning what their approach was, what they'd be doing, a little bit about the theory. So if you want to watch all 3 of these, you can find them on YouTube. You don't necessarily need to like for the exam, but if you're interested to see the therapist then, and then maybe see pieces of it that might have continued on till now as we continue on in the chapter, I think it is a really useful thing to see, especially if you think you might want to go into therapy. You would be hard pressed to find therapists today that do things exactly the way these 3 examples throughout the documentary do, but you might be able to see and connect some of the pieces that we've taken from these previous researchers and therapists.
Good morning.
Hello, Dr.
I'm Dr. Rogers. You must be Gloria.
Yes, I am.
Let's have this chair. Well, we have half an hour together, and I really don't know what we'll be able to make of it, but I hope we can make something of it. I'd be glad to know what.
So half an hour or an hour is quite a short time, especially when we're talking about one of the most important pieces being that therapeutic alliance. So this person knows that they're going through and testing out and showing the therapies of these different individuals. So is she actually trying and motivated to build that kind of alliance with any of these people? I think that'd be hard to say that she is. But that is one of the critical pieces that you might not see in any of these three, is building that alliance. You might see it from the therapist side to the patient, but I think it'd be hard for a patient in that kind of context to try and also give that motivation going back the other way.
Whatever concerns you.
Well, right now I'm nervous, but I feel more comfortable the way you're talking in a low voice, and I don't feel like you'll be so harsh on me. But,
I hear the tremor in your voice, so
well, the main thing I want to talk to you about is I'm just newly divorced, and I had gone in therapy before, and I felt comfortable when I left, and all of a sudden now the biggest change is adjusting to my single life. And one of the things that bother me the most is especially men and having them into the house and how it affects the children. And the biggest thing the thing that keeps coming to my mind I want to tell you about is I have a daughter, 9, who at one time I felt had a lot of emotional problems. I wish I could stop shaking. And I'm real conscious of things affecting her. I don't want her to get upset. I don't want to shock her. I want so bad for her to accept me. And we're real open with each other, especially about sex. And the other day, she saw a girl that was single but pregnant, and she asked me all about, can girls get pregnant if they're single? And the conversation was fine, and I wasn't at ease at all with her until she asked me if I'd ever made love to a man since I left her daddy. And I lied to her. And ever since that, it keeps coming up to my mind because I feel so guilty lying to her because I never lie and I want her to trust me. And I almost want an answer from you. I want you to tell me if it will affect her wrong if I told her the truth or what.
And it's this concern about her and the fact that you really aren't, that this open relationship that has existed between you now, you feel is kind of...
Yes, I feel like I have to be on guard about that because I remember when I was a little girl, when I first found out my mother and father made love, it was dirty and terrible, and I didn't like her anymore for a while. And I don't want to lie to Pammy either, and I don't know...
I sure wish I could give you the answer as to what you should tell her.
I was afraid you were going to say that.
Because what you really want is an answer.
I want to especially know if it would affect her, if I was completely honest and open with her, or if it would affect her because I lied. I feel like it's bound to make a strain because I lied to her.
So because she'll suspect that, or she will know something's not quite right.
I feel really inclined she'll distrust me, yes. And also...
So even just this short interaction is actually a really good example of some of the aspects of Roger's humanistic therapy. So there you can see in many ways he's kind of just parroting back what she has said. So that it shows that he understands, it shows that he's caring to listen, that he is seeing that, well, hey, she wants this therapist, this authority to say, yeah, it's okay that you lied to your daughter, or no, it's not okay. But like he says, that is not something that a humanistic psychologist therapist from this approach would do. So if it was another person, another therapist, maybe one now, they might say something like, well, the stats say, for example, that I'm literally just making up stats right now as an example, just to be clear. So a therapist might say something like, well, about 20% of parents lie about their sexual activities to their children. Children, on average, 70% of them said they don't really want to know about the sexual activities of their parents. So, on average, it's probably, most kids probably don't. Your child, maybe they do. So, and then might go like that with some like broader, more general stats to kind of explain and get at an answer without actually giving an answer, saying, oh yeah, that was bad that you lied to your child, or no, that was good that you lied to your child. But that's not what a humanistic therapist like this would do. You definitely see a lot of that kind of giving the space for the person to express themselves, express their fears, express their troubles. But you might also say, well, I see some weaknesses in this approach too. And that is a perfectly valid criticism as well, which is why there are multiple different kinds of approaches, and why one of the current biggest approaches for doing psychotherapy is actually cognitive behavioral therapy. But we'll talk about that more in just a minute. Let's watch just a couple more minutes, but not this entire video.
So I thought, well, gee, what about when she gets a little older and she finds herself in touchy situations? She probably wouldn't want to admit it to me because she thinks I'm so good and so sweet. And yet I'm afraid she could think I'm really a devil. And I want so bad for her to accept me. And I don't know how much a 9-year-old can take.
And really, both alternatives concern you, that she might think you're too good or better than you really are.
Yes.
And she might think that you're worse than you are.
Not worse than I am. I don't know if she can accept me the way I am. I think I paint a picture that I'm all sweet and motherly, and I'm a little ashamed of my shady side, too.
I see. It really cuts a little deeper. If she really knew you, could she accept you?
This is what I don't know, yes. I don't want her to turn away from me. And I don't even know how I feel about it, because there are times when I feel so guilty, like when I have a man over. I even try to make...
So I think that that's probably enough of watching this one. Feel free to watch this whole documentary if you'd like. It is pretty fascinating to see the different approaches. The patient doesn't always bring up the divorce. They often, I think in 2 of the 3, they start with that. But then based on the prompting of the therapist, sometimes they go off in different directions. With the daughter, the psychodynamic therapist, they talk about their childhood, for example, and their parents and whatnot. But it is interesting to see the different approaches, especially after reading about them in the book or talking about them here in class, to see how they actually played out. But I think you can also see how the humanistic idea about humans, that having essentially believing that a person can find things on their own, that they can find solutions on their own, is a big point of this. Like Rogers here thinks that this person can get to a good solution on their own, and is trying to provide an environment to allow this person to get there. So even though the patient at sometimes might be a little frustrated that they're not getting a straight answer, that is kind of the basic philosophy and what's driving a lot of the behaviors of the therapist in this example. So questions about that specific interaction at all, or humanistic psych, or how it's related to some of these other, I mean, right now we've only talked about humanistic and psychodynamic. Feel free to either raise your hand or put up a question in the chat box as well. So behavioral therapies, like applied behavioral analysis, these are ones that are focused on behaviorism specifically. So the overt behavior change, the things that you can see, behaviors that you can see, observe, rather than the insight into a person's self or any kind of underlying causes. So if a behavior is biting, not understanding the basics of why does the child think it's okay to bite, or why is that their motivation to then bite someone, but the actual behavior of biting, let's get rid of that behavior. And so with that, you can go back to chapter 5 on learning and operant, and so classical and operant conditioning. And so what behavioral therapies are using are going to be operant conditioning generally. They might use classical conditioning too, but very often operant conditioning. So currently, applied behavioral analysis is mostly using behaviorist therapies. So the goal of these is to reduce or eliminate those maladaptive behaviors, biting, it can be really any maladaptive behavior that a parent wants to get rid of in a child, or that a teacher wants to get rid of in a child. Maybe a child is talking too much in class. So getting rid of that specific behavior, not caring about the motivation of why is the child speaking out in class so much, but let's stop that specific behavior. So more recently, especially with ABA therapy, there are social cognitive approaches that have mixed in. So the fields now, as opposed to maybe 30, 40, 70 years ago, are doing a lot better job working together and realizing that, hey, we don't have to be these totally separate schools of psychology. We can all kind of work together to solve problems. Part of that was caused by literal schools, so like physical buildings in space, like a school in Chicago versus a school in DC versus a school in Washington versus a school in New York, that there were literally schools where Freud's ideas would be the primary one taught. And so you would go there and you would know you were going to primarily be getting this psychodynamic approach, if exclusively even sometimes. There were other schools where, say, Rogers would, I don't think he ever lectured, I don't know for sure, but where they would teach a humanistic approach versus a behavioral approach. So it would be literal schools around the country that would kind of have a rivalry, a psych rivalry. Hey, we can treat patients best with our exclusively humanistic or our exclusively behaviorist or exclusively psychodynamic approach. So it is how we started, and we've moved past that. So I feel like it was a little bit of a disservice to not start working together until more recently, but you know, humans, sometimes it takes us a little bit to learn these things, right? So classical conditioning techniques are things like systematic desensitization. We saw this in the video of the snake. So trying to just make that behavior of fear of the snake extinct, not because of the action of the patient in that video. So they weren't reinforced for doing things. It was just essentially conditioning to realize and associate, hey, this snake is not so terrifying. So doing things like applying relaxation and imagining fearful scenes at the same time. Now a lot of VR is used. So rather than actually bringing a snake into a room, you can put on a VR headset and much more easily have an experience on a roller coaster, or go up different heights on the side of a building in a really safe and controlled environment. Versus, I mean, probably the environment is a lot less safe for the snake than it is for the human participants, but definitely safer if it's a VR snake. So aversive conditioning is pairing an undesirable behavior with an aversive stimuli. So this gets more into operant conditioning. So we talked about operant conditioning and trying to stop nail biting behaviors with bad tasting nail polish. So that would be an aversive stimuli on the nails. So that would be an aversive pairing, aversive conditioning. So you could associate alcohol, you could pair it with a nauseating drug. So there are specific drugs that when you take it and you drink alcohol, then you'll have a more dramatic nausea response. And hopefully the idea would be that you will learn an association that the stimulus alcohol leads to that nausea. You'll essentially get a taste aversion to alcohol from using this method. You can do that with other things. I've heard of it being done with cigarette smoking as well. So people who are wanting to get rid of their cigarette smoking, they will do something like this, and then feel that it's more nauseous associated with that. And then they're less likely to want to then smoke. So operant conditioning techniques, things like you would use consequences. Positive, negative reinforcement tend to be the most effective and most long-lasting, as we talked about in our chapter on operant conditioning. Using the schedules that are variable are better. So a variable ratio, so reinforcing, as an example, for a client that we were trying to have when they got upset, like visibly upset, we wanted them to like take a step back, like literally step back from whatever they were doing, turn away from it, and then take a breath. Those are the behaviors we wanted to see, because cognitively we knew doing that gives them a little bit of space, lets more chemicals like cortisol levels drop a little bit. Taking a deep breath helps other chemicals be released and other hormones working. So it's cognitively impactful, but that was the behaviors we were trying to see. Rather than seeing anger or fighting or yelling or throwing a Monopoly board all over the place, which honestly, I understand throwing the Monopoly board. This is why I don't play Monopoly. But anyway, the main point is trying to see that behavior. We would positively reinforce that behavior. We would positively reinforce when they turned away, when they took a step back, when they took a breath, with things like negative reinforcement as well as positive reinforcement. Usually positive reinforcement, just because it was easier. We would say give them a reward, like they got to play dodgeball at the end of the day or something like that, or go to the local video game store and play whatever games were able to be played if they did enough trials successfully, essentially. So with that, a lot of applied behavioral analysis uses operant conditioning, and you're trying to extinguish those maladaptive behaviors. You will most likely not see an applied behavioral analysis punishing behaviors, either using positive or negative punishment. Usually you'll see reinforcement. And again, positive reinforcement, it's easier to do in a lot of cases. It can be really effective in children, especially because children have a harder time talking about their internal sense of self, like how are they feeling? We're trying to teach my son emotions and like how to identify his own emotions, and it's hard for him. He's learning it. It's a process of learning. So in his age at 3, sometimes it's easier to just do positive reinforcement for doing proper behaviors. So that's what we're doing right now for like potty training. He gets to do stickers. He gets stickers or gummy worms when he goes potty in the potty. So he's doing really good too. So hopefully by the time we have class again, he'll be, actually, I won't say that. I will not put that out into the universe to let it get screwed up. So I probably said too much already. Sorry, universe. Shouldn't have said anything. I'm just kidding. I'm not actually superstitious. I'm just trying to be funny, because it is a stressful thing to potty train. Yeah, I better. After saying that, I probably should go buy a big bulk thing of diapers for sure. Do the Target one so you can get the $50 gift card or whatever for buying a ton of diapers, and you use it on more diapers. That's our strategy. Positive reinforcement, or would that be, yeah, giving the gift card. So giving the gift card is a positive reinforcement for us from Target to continue buying diapers from Target. So the basic for behavioral therapies, it doesn't really matter what the actual core of the problem is coming from. It doesn't matter what the motivation is for whatever behavior. You're trying to change the behavior, and that's the key. And you're using a behavioral technique to change that behavior. Cognitive therapies focus a lot more on the source of psychological problems. So as I mentioned earlier, cognitive behavioral therapy is one of the most popular, and it's essentially a combination of this cognitive and the behavioral that we just referred to. So cognitions are the primary source of psychological problems. So whether this be our own thoughts or ideas about the things that make us anxious, our own mental spirals, upward or downward spirals. So thinking about things that are stressful and being worried and then being more stressful and worried, that kind of cognitive process can be a source of other psychological problems. Even some of the psychological symptoms that we might see, like an auditory hallucination, maybe it's caused because of that anxiety and those cognitions. So some assumptions, cognitive cognitive therapists make is that people can control their thoughts, that people can control their feelings. And so again, having that kind of control over feelings, neurotypical development for regulating emotions, by the time you're about 23, you should be pretty good at regulating emotions, right? For a 13-year-old or 14-year-old, you might not be as great with it, especially with starting puberty and those areas of your brain like the amygdala being myelinated a little more. You might even be a little bit worse than someone who's, say, 10 at regulating some emotions, because at 13 or 14, maybe you're feeling them stronger and more emotions. So are these great assumptions for every single particular case? Not necessarily. So I know my 3-year-old cannot always control their emotions, right? So an exclusively cognitive approach with a 3-year-old is probably not the best approach. But for an adult, probably a better assumption to make. Also, an assumption that people can reinterpret events and experiences. So looking back at either a positive or negative experience in childhood, that we can then reinterpret that, recontextualize that, and see it in a different way, in a different light. So the emphasis of this is on those thoughts, those cognitions. So, and the idea that how we think will control how we also feel. And it's a focus on overt problems rather than unconscious, unknown motivations like Freud, but the problems that we present with. So you would ask someone, hey, what are you struggling with? And if they say, I'm struggling because I can't reach out to people, I feel really sad, or I feel really anxious, or I have these specific symptoms, you look at those overt problems. You don't take that statement as some kind of sign of an underlying unknown motivation from that patient, like the psychodynamic approach might. You would have structured analysis and specific guidance for specific kind of things. So Rogers would, like you saw there, have just kind of a safe space for people to hopefully work through their problems and their stresses and anxieties with a supportive person who is giving them unconditional positive regard. So rather, for cognitive approaches, there's well-researched ideas of, hey, if these are your symptoms and this is what your overt problems are displaying as, we can do 1, 2, 3 ABC, and that should help. So specific analysis, specific guidance, assessments are common for cognitive therapies. So valid assessments, whether it be scales, or we talked about projective tests during personality assessments, MMPI or MMPI-2, those kind of assessments would be used by a cognitive therapist. So the goals of therapy are that cognitive restructuring. So reinterpreting things, learning new skills is another cognitive thing. So finding your own illogical, automatic, negative thoughts. So what are the habitual cognitive behaviors you have? So what are the negative thoughts that you default to? So that's part of your learned process, that now this negative thought comes up all the time. Similar to habits, our neurons, how they work is in those networks, right? So the networks that are used the most are the most easy to fire. So if those negative thoughts are the most easy to fire, you're going to come back to those negative thoughts. So if you identify and challenge those automatic thoughts, if you reinsert a new thought or have that, or you break that network essentially of those negative thoughts, now you won't be thinking those negative thoughts. So there is both biological evidence for these kinds of therapies, as well as experimental evidence as well. So you might have irrational or self-defeating beliefs. So changing those through like the behavior of identifying and challenging those thoughts. Oftentimes we ignore evidence of positives. So we talked a little bit about this in social psych, that we tend to attribute maybe our failures to other people, but we also oftentimes ignore evidence of positives, especially when we have negative symptoms. or suffering from things like depression or anxiety. So we often overgeneralize negatives of ourselves as well. We magnify the importance of those negatives. So yeah, it might be a negative thing that I have a hard time reaching out to people, but that doesn't define me, just as an example. Absolutist thinking, like exaggerating your own imperfections. So trying to get rid of those automatic thought processes. And so these are the symptoms that you might display as. And so a cognitive therapist would work to change the cognitive processes in these things. So cognitive behavioral therapy essentially takes that cognitive piece, that behavioral piece, smashes them together. Sorry, my throat is feeling dry now. So some of the ideas, again, here are the same as the others in cognitive therapies. Reducing those self-defeating thoughts. You want to incorporate behavioral therapy. So if there is overt behaviors, changing your default processing about your ideas around those behaviors, as well as reinforcing different behaviors. Maybe you'll reinforce actively thinking a different thing than those self-defeating thoughts. Self-instructional methods, so giving people tasks, homework to do, try this, learning new skills and techniques. As an example, for anger management, you could learn lots of different anger management techniques. So as well as for the clients that I worked with, we did a pretty much exclusive behaviorist approach. But if we had done a cognitive behavioral approach, we might talk more about many other ways you can reduce anger. So letting people take breaks, encouraging them to do that. It's called tapping. So essentially you take your hands and you focus on your hands and you move them up slowly and then down slowly. So like you can do your full range of motion. You can do it just a little bit. Obviously, like if you're in an office meeting, you don't want to, you want to learn the skill to be able to do it and focus on your movement and move very little bit, versus in the office meeting, you don't want to be like doing this because then you might just get funny looks. So learning new skills, essentially. So learning new skills, reducing those self-defeating thoughts that are kind of an automatic process that you've learned. Yeah. So e-therapy interventions. I feel like the book this is an area that a lot of different apps and computer automated systems have been coming out on an accelerated rate. So one, I think that your book is behind. Two, I feel like research lags behind here. And three, I feel like it's also an area that people who are trying to make money have exploited as well. So there is evidence of a lot of health-related apps and e-therapy interventions working really well. With that being said, with the massive number of different kinds of e-therapy apps that exist, I think you'd be hard-pressed to say that all of them will show the benefits that some of them have shown. Yeah, I said that right, yeah. So we've seen positive benefits in lots of different ways from some of them. It's hard to know if that result is exclusive to that specific method and that specific app in that specific context, or if that would also generalize to other apps. Yeah, that was a little clearer. All right, so cyber therapy is just internet-based Skype with the therapist. This is actually really, really common right now during COVID. Is most, if not all, therapy is at a distance. So Skype. So with that, a lot of these e-therapy interventions, and even if you're trying to find a therapist that does video methods, a lot of sites that host a lot of different therapists don't necessarily include qualifications. So if you want to find someone who, let's say, you're struggling with anxiety or something like that, you want to find a therapist who is well suited to treating that. We talked about that a little earlier. So it can be hard to find that information on some sites. Usually, this is also not the best method for suicidal patients. They definitely need more, especially if they have that desire and the means. They need more direct one-on-one intervention. So positives is that it does make it more easily accessible to a lot of people. Um, Even just commuting time, cutting down on that can make it a lot easier for someone to get that help. So also, if you can start with an e-therapy intervention, get to the point where you could go to another kind of intervention. Maybe you're talking to just a robot as an e-therapy intervention. And then you get to the point where you can do a cyber therapy, like a Skype with a therapist. That can be really helpful. So some therapists, I mean, this isn't really relevant right now because most therapists are doing almost exclusively e-therapy. You might find therapists who will do some in-person visits and some e-therapy. They might even give you special online tools that you can use as well. Yeah, this is an interesting thing. I have a friend who's a therapist, and he actually moved towns. Like he moved a couple 100 miles away from where he was living, uh, and he set up a new practice there. And one of his clients is still working with him. So even though they live at a distance, that client is still has such a good therapist patient alliance that client is still working with them. And same thing with a client moving away and still working with that original therapist. Both of those examples are actually in Australia. I'm not sure insurance in the US would allow for that, which is unfortunate. But I don't know that. I don't know that for sure. So a better method. So we've talked about biological approach. We've talked about psychological approach. We've talked about humanistic approach. It can be really useful to look at biological, social, and psychological factors. So if you look at this little Venn diagram, uh, you can teach someone specific psychological skills like coping skills or social skills or changing attitudes and belief, changing those mental processes of habitual negative thoughts. You can change biological things, maybe having medicine, for example. You can change the social environment as well. Well, you might be able to, depending on what you're doing. So you can improve programs for people with low socioeconomic status. You can improve schools. You can improve workplaces. So doing all those things together, the biological, social, and psychological, those all together are very helpful. So not focusing on just one, similar to not focusing on just one school of psychology, is really helpful. So let's take a quick break right now. We will come back at about 8:34. So let's take a quick break right now before we move into other areas of therapy. All right. Looks like it is time to continue. So, honestly, there's a lot fewer questions. I mean, probably a lot of this is because rather than being an in-person class, we're a broadcast class right now, and it's the day before a break. So, but we are definitely going through a lot of this quicker than usual. So feel free to ask questions. I don't know absolutely everything about all therapies, but um, I know a lot, so we can talk about it for sure. All right, so let's talk about biopsychosocial model of treating abnormal behaviors and give a couple examples of that. So with this, um, let's talk about ADHD. So you might use cognitive behavioral therapy to treat maybe the specific things of not being able to focus. So teaching new skills, new techniques to be able to focus better. Learning to take breaks, for example. So a therapist might talk about that, like, hey, when doing studying, take breaks every 20 to 30 minutes and do something very different on the break, similar to what we talked about in our memory course or our chapter on memory. So giving those skills, so teaching new coping skills, changing attitudes about symptoms. So rather than seeing them as maybe a negative, see some of the abilities that you might have from it, from being, making it a hard time to focus attention, but at the same time being able to switch attention to different tasks could be a positive if used correctly. Um, so doing those cognitive things as well as drug therapy treatment is really effective for ADHD specifically. So many different disorders and neurodivergent things respond well to both cognitive behavioral therapy as well as drug treatment. So we're doing that psychological, we're doing that biological. It is hard for a therapist to do much about the social environmental. They will often ask the person to change something in their environment. So if they can get a different shift at work, that is an example of something that they might change for environmental. So if someone's not getting enough sleep and it's affecting their insomnia, maybe getting a different shift. So rather than like the night shift, maybe they're on first shift, and that might be better for them. Seeing different people regularly might change or help to work with, say, grief or trauma. So there are things they can do. A therapist in and of themselves probably isn't going to be able to change the socioeconomic status of all of their patients, right? But doing our best as psychologists, as therapists, as people that might be working through things to think about the biological approaches and the biological factors affecting disorders, psychological approaches and psychological factors, and the social and environmental approaches and those factors that are affecting these disorders. I feel like that jumped further. Nope, I guess not. So let's talk about a bunch of different biological therapies in some detail. So here we're going to focus a lot of our time on drugs, but we are also going to talk about electroconvulsive therapy and psychosurgery because those are still used in specific cases, and they're very different than the really terrible things that used to be done with electroconvulsive therapies and psychosurgeries. So essentially, biological therapies are, again, trying to reduce or eliminate symptoms by altering body functions. So usually with drugs, it's neurological functions. So what kind of neurotransmitters are prevalent or present, or what neurotransmitter receptors are doing. So altering those things generally, not always, but generally. So let's talk about anti-anxiety drugs. Some of these are tranquilizers as well. Essentially, they're there to induce calm. So benzodiazepines like Xanax, Valium, and Librium are examples of benzodiazepines. I'm not sure I pronounced this one correctly, but buspirone is used for more generalized anxiety disorder. Generally, these are used temporarily. So, for example, using a pill of Xanax when the anxiety is really bad, rather than as a consistent, constant thing. It would be using these for a temporary thing. So let's say, I don't know, just as an example, there's a wedding coming up and there's a lot of anxiety around the wedding or something like that. Maybe using it regularly for a few days or something like that. A big problem with these is that they are often overused. A lot of anti-anxiety drugs here are often overused and can become addictive. So that can be a big problem. So usually it's only recommended to use them temporarily. If it isn't being recommended, if, for example, if you're ever using one of these and it's not being recommended for a temporary duration, check, maybe get a second opinion, look up the drug and the possible side effects, and at your specific dose, if it looks like you are at risk for becoming addicted to it, because hopefully the doctors are going to be taking that into account. But I mean, also be responsible as well to understand what these might be doing. I know it's a lot of documents that come with various prescriptions, but read those too. Yeah. So antidepressant drugs are used for a bunch of different disorders, actually, because of the neurotransmitters that they influence. So what these are usually influencing is serotonin, or also, do I not have it listed here? Norepinephrine. So norepinephrine and serotonin are the two most common neurotransmitters that it's affecting, either increasing the presence or decreasing them, or increasing the response of the receptor cells in dendrites. So many of these influence serotonin or norepinephrine. So most of these improve depression moderately. Some of the best treatments for depression are an antidepressant as well as cognitive behavioral therapy. So so the therapy by itself, and I don't think I have a graph on here. I think it was in your book though. So for depression specifically, the antidepressant itself does a better job than placebo or no therapy at all. So the antidepressant works and the therapy works at about the same rate on average, but putting them together does a much better job. So with that, we'll talk about a bunch of different antidepressants. One key thing here is for any individual and their own individual biology, kind of trying to figure out which one is working, because it can be hard to diagnose and see, okay, you don't have enough serotonin, or that it's your receptors are not sending enough of the message afterwards. So depending on the specific drug and your own specific body chemistry and your own specific neurotransmitters, certain drugs might work better than others, and it can be hard too, because they take a couple weeks to really work effectively. So many have significant side effects as well. So that's another problem when you're trying to, when as a doctor you want your patient to try this one and it will hopefully work, and then it's not working, trying a different one. Well, even though that one might work a little better, maybe it's got worse side effects. So it's kind of that balancing act. And a lot of these take more than 2 weeks to work effectively. So taking the antidepressant on day one, you should probably feel no different, because it has to start getting into your system, getting those neurotransmitters at the correct levels, like stabilizing that, and then it has to be taken really consistently as well. So if you forget, maybe depending on the antidepressant, this isn't true for every single one, depending on the antidepressant, if you miss one day, it's probably not going to knock you completely out of the cycle. But if you miss like 3 or 4 days, you might have to restart. You're essentially restarting that medicine again to get to that 2 weeks for it to work again, or maybe a little shorter than that. So with this, a lot of antidepressant drugs are also used for anxiety, sleep, chronic pain, ADHD. So when I was using, I did use an antidepressant for ADHD in my teen years. I don't remember which one it was now. I'd have to look at my medical records. But that was more effective than the stimulants that are also a possibility for ADHD as well. So One class, so this is a category of antidepressant drugs, is tricyclics, and these increase norepinephrine and serotonin. They are some of the most effective. So there's a lot of different specific like drug names that are actually tricyclics. There are NASSAS. I think there's a shorter way to say that, but these are also going to be increasing norepinephrine and serotonin. And then MAO inhibitors block the reabsorption of those neurotransmitters. So they're doing a little bit different things. So these, the tricyclics and the NASSASs, are increasing the norepinephrine and serotonin, versus the MAO inhibitors are inhibiting the reabsorption of norepinephrine and serotonin. So the end product is still you have more norepinephrine, you have more serotonin in between those synapses to be able to be used, but they're doing it a slightly different way. So for one person, one of these drugs might work, but for another person, the MAO inhibitor might work better, just because of what their body chemistry in their neurology is actually doing. They might need that inhibited because maybe they're actually producing enough, but it's reabsorbing it too quickly or too much of it, those kinds of things. There's also SSRIs, and these stop reabsorption of serotonin specifically. These are some of the most commonly prescribed antidepressants, and they do have some of the fewest side effects, so that's one of the reasons they are tried. Very often they're tried first, and SSRI will be tried first, versus some of the tricyclics. While they're some of the most effective, they can have some more serious side effects. So there's more resistance for a doctor, like, hey, try this one that might work and has less side effects. If that works, then awesome, versus going with the one that will probably be effective but also might have negative side effects. They'd be more reluctant to try that, essentially. So that's kind of what they do in their specific training for the drugs, is the psychiatrist would be learning about the side effects, the biology and chemistry of how it works. So that's some of the main reasons that psychiatrists and those that are medical doctors do prescribe drugs, versus psychologists in some states now can. They do need that specific training in pharmacology, though. All right, so most antidepressant drugs take up to 2 weeks to really start to affect things, to really start to affect the norepinephrine, the serotonin, to affect the reabsorption of serotonin, or to change the MAO inhibitors. To a degree that you can actually observe things, it can take up to a couple weeks. So this can be really difficult for someone to notice the changes in their behavior, especially when it's over the course of 2 weeks, changes in their mood, things like that. It can be hard to see that. I mentioned the problem if you miss a couple of days, it might mean you're having to restart that kind of 2-week cycle. So those can be challenging. So even when you're using it for these other options like sleep, anxiety, chronic pain, ADHD, for chronic pain, as an example, you want something like an ibuprofen or an Aleve or something that gets rid of the pain right away. But for chronic pain and taking an antidepressant, it can be up to 2 weeks before you see any kind of change at all or feel any kind of change, because that's how long it takes for it to really be starting to work. So you've got to be patient with this one if you're using an antidepressant for any of those kinds of treatments. And follow the instructions on taking it too. Essentially all of these drugs, don't stop taking it without talking to your doctor about it. So for bipolar disorder, one of the common ones is lithium. And lithium is toxic. You've probably heard of it as like a toxic metal, right? Yeah, lithium is, I think, a chemical. I think it's a metal, isn't it? Anyway, it does treat the episodes of mania really well, but it doesn't do as much for the depression. Like we talked about last time, some of the most common symptoms for someone with bipolar disorder are the symptoms of depression. So you tend to have, just on average, someone who has bipolar disorder will tend to, on average, have more periods of depression or longer spans of depression and shorter spans of mania. So if they're going to a psychiatrist, maybe for a whole year, they're on an antidepressant, and then it appears that they're moving into a stage of mania or an episode of mania, they might change to lithium over the course of that 3 months, 6 months, whatever it is, and then back to an antidepressant medicine. So antipsychotic drugs tend to try to reduce tension and the anxiety around the psychoses symptoms. So the hallucinations, for example. So, and also try to decrease hallucinations. So neuroleptics are affecting dopamine pathways, and dopamine does a whole bunch of different things in the brain. So with that, they can be really useful in treating symptoms of schizophrenia. So some of those positive symptoms that we talked about. So again, that's adding something to the situation, things like hearing voices and things like that. So they can be really useful there. So with this, I looked this up again to say it correctly, but I know I'm going to mess this up. Tardive dyskinesthesia is essentially a side effect of a lot of antipsychotic drugs, not just neuroleptics, but a lot of different antipsychotic drugs that are used that causes involuntary muscle movement in the face, tongue, mouth, arms, and legs. And it can be really distressing for the person who's experiencing it, and it can be distressing for people around them as well. So if those side effects are too bad, that might lead to even more anxiety than some auditory hallucinations for that individual. So that is one of the important reasons to be talking to a doctor, maybe both a psychologist and a psychiatrist, about the symptoms that you're experiencing as well as the effects of the drug. Because if you have these involuntary muscle movements and it's affecting your day-to-day life and you feel extra anxiety about that, well, then you can work with that therapist as well as psychiatrist and maybe reduce the dosage on the medicine, learn some coping techniques so that you don't have as much anxiety around these involuntary muscle movements, or even stopping that drug entirely. But depending on your symptoms, that might not be an option to get rid of some of those symptoms of, like hallucinations, for example. You might need to be on that. So other antipsychotic medications might be affecting dopamine and serotonin. But with that, these atypical antipsychotic medications might be really bad for white blood cells. So with that, for antipsychotic drugs, a lot of people who are having psychotic symptoms will be needing both a medicine as well as therapy, and to be monitored. As you might see here, and from your reading in the book, the drugs that we have, while they're better than maybe some of the treatments that we had a couple decades ago, are still not the best. So there still are a lot of negative side effects, and they tend not to improve as much as we'd probably hope for any of these drugs. Not to say that they're useless to take, but oftentimes with therapy, they're more effective. So doing both that biological, social, psychological model, biopsychosocial. All right, so let's talk about electroconvulsive therapy. So in horror movies, for example, you might have seen someone put some electrodes on the side of someone's brain and zap them, right? Maybe it's a monster movie or something, and that's how the monster came to be. And that's a lot of times what people know about electroconvulsive therapy. The point of it is basically taking a small electric current. It shouldn't be dangerous, to produce a really brief seizure. So with that, it is still used. Electroconvulsive therapy is still used for a couple specific problems. One is to treat major depressive disorder. Oh yeah, so good input there, Des. Thank you. So So I'm just going to read this, maybe not necessarily word for word, but the recording doesn't actually record comments, which in some ways is good, some ways is bad. But here, electroconvulsive therapy is widely more common than expected, and Des was super surprised. One of your question papers was written on it, seeing how common it was with medical billing and charity applications. It was probably one of the most common behavioral health things I come across personally, other than psychotherapy. Yeah, so it's a lot more common than I think a lot of people realize, because a lot of people's experience with it is that like scary horror movie kind of thing, shocking someone's brain. So you are shocking someone's brain, but it's a lot less dangerous or scary than it sounds. So let's actually watch a modern electroconvulsive therapy session. Well, an explanation, an example, and for the life of me right now, I can't remember transcranial something stimulation is, I think, TMS. It's similar to ECT. But let's watch these really quick to give you a better idea of what it's actually used for and what it actually looks like. So hopefully you can leave class, and then when you see it used improperly in a video about psychology, you can go, haha, that's not really how it's done. And then you can explain to all your friends that it's really not such a weird or scary or crazy thing. So let's watch it. It's enough preamble about it.
My name is Irving Retty, and I'm a psychiatrist and director of the brain stimulation program at Johns Hopkins Hospital. At our clinic, we treat patients with electroconvulsive therapy, also known as ECT, as well as transcranial magnetic stimulation. ECT is the most effective treatment we have for depression and other serious mental illnesses, but it causes memory loss and requires general anesthesia. Knowing more about how ECT works could help design non-convulsive forms of direct brain stimulation that are as effective as ECT, but that do not cause memory loss. My research focuses on learning more about how ECT works and developing alternate non-convulsive forms of brain stimulation. We use mouse models of depression and other conditions to learn about the molecular and circuit level changes in the brain that underlie the therapeutic effects of brain stimulation.
All right, so let's now watch an example of it being done.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or who are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
It's typically indicated for treatment-resistant psychiatric conditions, most commonly mood disorders or depression, but there are multiple types of depression, so it can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
When the patient's asleep, the stimulus is delivered, the seizure is monitored, they'll have just one seizure.
An electrical current is given to the brain, low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. And thanks to the anesthetic, it's very hard to tell. In fact, only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens soon after and is monitored for a short while like any patient who has undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown for the WVU Health Report, I'm Dr. Raleigh Sullivan.
So let's watch the one, especially since these are also short. Transcranial magnetic stimulation is, I think, the TMS. It's a little bit different.
Each year, Americans spend more than $11 billion on antidepressants, but studies show they can be ineffective in up to 40% of all patients. Bob Holmes was one of them.
They tried to adjust my medication, but the medication had side effects that were undesirable.
Holmes is among the 16 million people in the U.S. who suffer major depressive episodes each year, a number that has increased 18% over the last decade, which is why some doctors at UCLA Health are taking a different approach. Here, doctors are beaming magnetic pulses deep inside patients' brains to change the way depression symptoms are perceived.
We are used to thinking of the brain as a chemical organ, but it's also an electrical organ. The idea that by using non-chemical means we can change the brain and how it functions.
It's called transcranial magnetic stimulation, or TMS. It's currently FDA approved only to treat depression, but doctors say it may prove helpful in a wide range of conditions by rewiring a network of signals in the brain.
What TMS is doing is changing how that network functions, really rebooting the network to improve symptoms of mood, anxiety, and chronic pain.
Which may be why many patients treated for depression also say it helps relieve their pain, raising provocative questions about whether TMS could one day become a viable alternative to opioids.
This is a really transformative kind of therapy, but in medicine there's always the wish to do better, to help more people than what we do now.
But for now, it's made a dramatic difference in Bob's depression.
It provided that kind of jolt to get my brain to start to work again normally.
At UCLA Health, this is Clark Powell reporting.
So hopefully you see from these that, well, it's a lot different than, I guess a lot of life is a lot different than is displayed in horror movies, right? But general depictions of electroconvulsive therapy are not that, right? Not such a, obviously you're going under general anesthesia. That's not a little thing for the ECT. The transcranial magnetic stimulation, you don't have to be under anesthesia for that. So is that a little safer? Definitely safer from the anesthesia, that's for sure. With that, they're kind of talking about resetting the brain. So essentially the seizure or the magnetic stimulation is kind of making the neurons stop working and then they have to restart working. So in a way, it kind of is resetting the brain. So it is kind of a big thing that it's doing, is restarting the process of these neurons. With that, though, if you do that and you have a neuron stop going through that negative habit-formed system that you're constantly going through, it might give you the opportunity to then make a new habit more easily through doing this. Now, in the future, I'm sure we'll do an even better job with like transcranial magnetic stimulation as well as ECT to be more focused at maybe specific areas of the brain that need to have that jolt to do those networks. But that also might be too different or unique in individuals, so it might not be able to be so focused. I imagine it will be, though. So as we move on with more additional research, also these videos in this research that I'm up on is a couple years old now. So maybe a good question paper too of what's it look like now. But it is very much just anytime you're under general anesthesia, it's not really simple. So I don't want to say simple and discount that. That in and of itself, being under general anesthesia, can be quite dangerous. But there are procedures that are safe and can be really effective for these specific disorders. It's not this kind of scary thing that they're often displayed as. They're also not used as widely as they used to be in the field. So when they were kind of used as kind of this scary, traumatic, terrible thing, they were being used way too much. Similar to psychosurgery. So one of the psychosurgeries we've talked about is prefrontal lobotomies. And so they were used on many, many, many institutionalized patients through the 60s and even into the early 70s. So sometimes they were used as a punishment. So you're sick of a patient's behavior, and so you give them a prefrontal lobotomy, and now they're calm and they're vegetables. So just terrible, absolutely terrible. In some cases, patients had to consent to allow a prefrontal lobotomy to be done for release from the hospital, like in their release papers, to say they would have to say, yeah, if it's requested by a doctor, I'll get a prefrontal lobotomy to then be able to leave the hospital. So super not ethical, especially if they're not reading that. They're not really given informed consent. You don't want to be trapped in a hospital the rest of your life, right? So essentially what this psychosurgery did was destroy links between the prefrontal cortex and the thalamus. So those links make a lot of essentially your personality disappear. So things like goal-oriented behavior are in your prefrontal cortex. Thalamus controls or is involved, is not controlling emotional processes and directing other things around the brain as well. So like connecting to old memories, things like that. So oftentimes patients seem to be very different, to lose their personality, and they were no longer maybe aggressive or doing behaviors that were irritating to staff, but they were also not doing behaviors that they would have normally been doing in general. So there are still psychosurgeries. So there are modern psychosurgeries used for obsessive compulsive disorder, depression, bipolar disorder. So let's watch this example of a modern psychosurgery used for obsessive compulsive disorder, and you'll see how far we've come with these kinds of treatments, and that they are not a first resort or you have to do this to leave a hospital, but they are still a possibility to treat specific disorders.
Tonight's Health Watch, encouraging news for people struggling with obsessive compulsive disorder or OCD.
Yeah, it's not drugs or talk therapy here. This is brain surgery. CBS 2's Dr. Max Gomez explains why this may be the best option for some. Dr. Max?
Yeah, that's right, Christine. You know, we've all seen some funny depictions of OCD. People who have to repeat certain routines like washing their hands or checking that the front door is locked over and over and over again. But severe OCD is no laughing matter. It's a disabling mental disorder. Randy Hurt has severe obsessive-compulsive disorder. It became so bad he couldn't keep a job.
I needed to take a shower, and I needed to do certain things. I needed to eat breakfast or whatever, regardless of how much time I had. I think it was 17 jobs in 4 years.
The obsession is something that is, the person knows is unusual and silly, but the person can't control it, and the thought itself causes marked distress.
The customary medication and talk therapy didn't work for Randy. Then his mother came across the possibility of surgery. It's called deep brain stimulation. Thin wire electrodes are inserted into tiny brain areas to disrupt nerve pathways that involve action, motivation, and reward processing. Small electrical currents disrupt the amount of reward a person assigns to their repetitive compulsive actions.
Patients are kind of fully awake at this stage, and we have a kind of a rating scale device where they rate how severe their OCD symptoms are at that time.
Over the next several weeks and months, the electrical settings are adjusted. Since his surgery 4 months ago, Randy can work on his car and mow the lawn, which he couldn't do before. But
I would like to work again at some point. I would like to get back to work.
I think we're just beginning to figure out the types of patients that we can help. And so I think there are quite a number of people that in the future are going to be helped by deep brain stimulation.
Now, even though deep brain stimulation has been done thousands of times for Parkinson's, epilepsy, and even depression, no one is advocating it for anyone but the most severe cases of OCD that have failed all other treatments. The procedure is FDA approved, and it's usually covered by insurance as long as you go through all the other treatments first.
Last resort.
Last resort.
Thank you, Dr. Max.
You bet.
It's a news report, so but they did a good job actually displaying the symptoms and the person's experience with it, as well as explaining it really quickly and pretty accurately and well. Which, so yeah, good job to those reporters there. So that is an example of a modern psychosurgery, in many ways doing a similar kind of thing as the prefrontal lobotomy. In this case, specifically messing around with or disconnecting or changing the electrical activity in a specific area of the brain. So it's more active, less active, but not such a broad and big and dramatic deletion of a whole part of your brain, but something a little more focused to the specific kind of motivations around the obsessive compulsive behaviors. So those are examples of modern psychosurgeries and modern ways that we're using electroconvulsive therapy. Again, most patients are going to be using the drug therapies, how they termed it there, talk therapy, so therapy, cognitive behavioral therapies. And then if those things are not working well enough or they're failing to work, depending on the kind of problem, a psychosurgery or electroconvulsive therapy might be an option in those kinds of cases. And hopefully, well, I'm sure researchers are curious, and the doctors as well are curious and wanting to do better with these psychosurgeries, with electroconvulsive therapies. They're going to get safer and even better as time goes on. So that's a good thing. Hopefully we get better and better drugs as well. So, sociocultural approaches. Okay, yep, we've got time to finish, I think, this chapter off. Questions, though, feel free to put them in the chat, raise your hand, because we have sped through this a lot quicker than I expected. That's all right if you don't have additional questions. That's totally fine. Sociocultural approaches emphasize on the social and cultural factors that are affecting any kind of disorder. So this goes back to our discussion of neurodivergence. So if a culture views something like autism or ADHD as neurodivergent rather than a disorder, the experience of a person with autism or ADHD might be different, or dyslexia, for example. So if they are seen by the culture and by the society as just having their brain working a little bit differently, rather than it being a disorder, it can change how people see them. It could change the stigma against them. If we change social and cultural factors around stigmas for suicide we talked about earlier today, or other mental disorders, depression, anxiety, things like that, it can change the experience that the person is living with, their own symptoms. Are they having negative thoughts about their symptoms? Are there obsessive compulsive disorder, or are there obsessive compulsive behaviors? Is that giving them a lot of anxiety, or are they not? Those kinds of things. So a lot of times the therapy approaches in a sociocultural approach are, again, the therapist probably can't change all the social cultural factors that are affecting people, but doing things like group therapy or family or couples therapy, bringing in more aspects of that person's context. So a whole family, so all the siblings, all the parents, a partner, all the partners, a group that is going through similar challenges in a similar geographic area. Maybe you've got a group of people who are suffering from anxiety in a specific city, and you are doing a group therapy with them so they can talk about maybe ways that they cope with it and how they've been using their behavioral techniques, what drugs are working for them, which doctors, which psychiatrists are that they're finding useful and helpful to talk to. So self-help and support groups also are another sociocultural approach. So with these, I often see self-help and support groups that are not doing research-based kinds of treatments. So if this is something you're looking for, there's definitely groups out there. I would say get some information from them, look up the data on the actual kinds of treatments that they're using. They might have specific kinds of names for them, but ask them like, where is this coming from? Is this like a psychodynamic approach, humanistic approach? Maybe not those, probably not those. But what aspects of cognitive behavioral therapy are they coming from? What researchers have done research on these kinds of things? Any single individual person going to these groups might not necessarily know that, but hopefully you can kind of narrow down and find if there is at all any research there. And now you've got a lot of research skills from doing these question papers, so that'll help you. So Desk gives a good suggestion here for those interested in searching. The Utah Center for Evidence-Based Treatment has amazing resources on their site and sliding scales for people looking for therapy. Okay, so it sounds like for that sliding scale, Desk, you kind of suggest like, I want something around in this area, I want like a focus this way or this way, and it kind of gives you suggestions. Is that what you're talking about there? Because that sounds great. Do be careful also about just that phrase, evidence-based theory, evidence-based treatment. Oftentimes, a self-help or support group might say, hey, we're evidence-based, and we're somehow really loosely tied to this one finding, and then we've taken it and run with it completely this different direction. So be careful of just that phrase, evidence-based. But it sounds like this resource, the Utah Center for Evidence-Based Treatment, probably is a good place to start searching as well. So thank you, Des, for that suggestion. Community mental health as well is, you can have communities as a whole do big group therapy sessions, focus on the mental health of kids in school, of people in workplaces, things like that. So treating people where they are and where they exist and where they live and where they're going to work in their homes. For the work I did with ABA, we therapy with kids, we worked in their schools and homes and in the communities for some of them. Some of them it was just school and home, some of them it was just community and home. But we tried to get more of these sociocultural factors in, try to make more changes or help get them more supports in these areas. If you've ever heard of an IEP, an individualized education plan, that's an example of a sociocultural approach. You're trying to change the culture of a school in a way that supports the needs of this individual student. And IEPs aren't necessarily only for mental health, but they can be as well. So generally for group therapy, you're going to see groups that share disorders. Professionals going to facilitate those therapy sessions. So some patients are generally further along compared to a new, like, first-time person. So depending on the dynamics, the group, you might need to build that relationship, not with just the therapist, but also the group. So that alliance, that therapeutic alliance with a group as a whole, rather than just with one individual therapist. And so in that, you might want to search for another group if you're not finding that alliance with that group. Family and couples therapy is very similar in a lot of ways. It's going to be oftentimes focused on things like cognitive behavioral therapies, to talking about things, validation, reframing, structural change, detriangulation. So looking at the problems people are having, trying to reframe them, teaching new skills, just like the anxiety or anger management skills that we've talked about. Oftentimes for any of these, you're going to be combining therapy types. I talked about these things already. Yep. So this is our last slide, actually, in this chapter. I thought so. So with this, do think about things from a cultural perspective, too. A lot of research is very Western focused. So when we think of an individualistic versus a collectivist culture, they might see different things as maybe symptoms or not symptoms, right? So having cross-cultural competence from a therapist is really useful, especially when they're working with people from multiple cultures, maybe multiple different ethnicities. So you don't necessarily need a match for your therapist to be your same ethnicity or from your same culture, but they should, just like they should have experience in the specific thing you're wanting to get treated, they should have some experience with other people or some knowledge of that culture, how it might be different, how it might be affecting your own context that you're in. And gender, with that, there's differing research. Basically, the biggest thing, the most important thing is not a gender match between a patient and a therapist, but that therapeutic patient alliance. If you do want feminist-specific therapies, there are definitely therapists that do feminist-specific therapies as well, though, too. So you can look for that if that's something that you would want as well. So we have breezed through chapters 12 and 13 faster than I thought we would, I think, during this break. So have a good Thanksgiving break. During that time, I will look back on the material and see if there's things that I really think we should focus on that I went too quickly over. Send me questions. I know this context isn't always as easy to state a question like in the moment. So thank you for being here today. I will definitely be sending emails to let you know exactly what's happening. Since now we've covered chapter 13, we breezed through that really quickly. I'll probably be going over specific things with chapter 13 or maybe just posting a video. So check your email before coming to class next Tuesday. And thank you very much for being here this evening. Thank you, Des, for giving us some good links last time and some good suggestions this time as well. And have a good break. Enjoy your time.